Thank you all. My talk will have 4 components. Component 1 is I want to tell you about measurement in groups, not individuals. Second is I will tell you the first results of Pure, which was published. But then I'm going to show you 2 new bits of data. One is the 8-year data on 7,000 events, which is larger than the entire literature put together. Okay? And then I'm going to show you a totally new method of analysis that will overcome some of the concerns around regression dilution bias, variability, and reverse causality. So the first thing is there are 2, we have to think of an experiment where we've got people where you measure sodium and then you want it related to events. I'm not talking about randomized trials. I'm not talking of individuals. In the experiments, there are 2 sources of error. One is the measurement of sodium. The second is the inter-individual variability of sodium. And the third is the precision in measurement of outcomes. So the first is we don't expect sodium to be arsenic or cyanide, only a moderate effect if there is an effect. So we need to have large numbers to pick up moderate strengths. We're interested in the shape of the association. So you need to be able to have large numbers of events in each subgroup. Say quintiles, you need several hundred events in a quintile. Otherwise, you can't characterize it. And we need an approach that is applicable to the general population. And general population has low risk. That means if you need a study of, say, 5,000 events and you have a 1% event rate, you can just do the multiplication. Therefore, we need very large population studies with a broad range of sodium intake so that you stretch out the exposure. You accrue several thousand events overall and a few hundred in each subgroup. And because we're interested in global applications and people around the world matter, so we're interested in individuals from many countries. So we need a simple, validated, standardized, widely applicable method to measure salt intake, or for that matter, the entirety of cholesterol epidemiology, the 90% of the blood pressure epidemiology, and most of the diabetes epidemiology is based on single measures, but large numbers. This is where the sort of debate on sodium, I think, has gone astray. And we need very large populations. Now, how do I move this forward? Okay, there we are. So the methods have been 24-hour urine collection as a reference standard based on conventional thinking. It's like in all these things, you never have a real gold standard. So you take something that you think is the best. Single urine samples, whether it is fasting or random, morning or afternoon, and dietary assessments, and I'm not going to touch that. It's been dealt with very nicely by the earlier people. All measures, 24-hour single, can be repeated to account for day-to-day variability and to adjust for what is called regression dilution bias. You get the same variability as you get with sodium with cholesterol or blood pressure. The R correlations are about 0.6 between 2 measures of cholesterol. But the way we adjust for it in big studies is you take a subsample, you assess the correlation, and use that to adjust for it. 24-hour urines has its problems. It's inconvenient, intrusive, high burden, and therefore you get refusals. The problem is the refusals are not random, so you have to be careful about that. And there is a non-participation bias. In most studies, it's about 25 to 30%. You can't get a full collection. And those who complete collection, obviously, are different from those who don't. And repeat urine collection, especially 24-hour urine, in a large study of 10,000 people, just impractical. So in the end, you have to, what is the key is you need the large numbers. Without it, you won't get the events. So you have to have your methodology that's balanced. So what we need is you take a subsample and you do repeated measures. You can do it in the whole sample, but that's not practical. So you do it in the subsample and use that subsample to correct things. And that's the standard methodology in cholesterol, blood pressure versus CVD. Or there is another clever trick. You measure glucose, your sodium, not in you measure it in communities. or groups of people, because it's not everybody on the same day over a 3-year data collection will be on a low or a high. They'll average out. So the community levels are remarkably stable over time. And is not subject to regression dilution bias, it's not subject to day-to-day variability, and it's not subjected to reverse causality. So the other one is intra-individual versus inter-individual variability. This you really need to understand to know what methods to use for different kinds of studies. For certain kinds, you have to control intra-individual variability. For other kinds, you need to control inter-individual variability. So to control intra-individual variation, we need more samples in the same individual, and I completely agree, you need 5, 7, whatever. Inter-individual, the only way you can control is by more people. So you do a tiny study of few hundred people, you're not going to control for inter-individual variability, let alone the variability in event rates. So in the variations in sodium in the same individual is 30 to 40%. It's not inconsiderable, it's significant. But the variations between individuals is 300 to 500%. These two variances are subsumed, they're not multiplied. So if you control this, you automatically control this. But if you control this, you won't control this. So then you have the rates of outcomes. And the smaller the difference you're interested in, the larger the number of events or people needed. So you need at least 100,000 average level individuals to get a good handle on the epidemiology of sodium versus outcomes. Whether it's single measurements, 24-hour measurements, it really doesn't matter. I'll show you that to you mathematically in a minute and with actual data. Or you need 10 to 20,000 high-risk people. The target mean you need a few thousand events, not a few thousand people. So we did a validation study, and it's important that your validation study needs valid methods. If you use a method that is not appropriate for your validation method, you're not going to get a great answer. So we did 1,083 people from 11 countries, the biggest validation study of sodium. We did first morning collection of urine at the end of the 24-hour collection. Remember what your morning urine is telling you? It's telling you what you ate the previous day and the day before. So if your 24-hour urine collection is after you collected the morning urine, which is what has been done in 2 studies, it is not an appropriate way to do your validation. Second is you can use a formula, and this should be the estimated creatinine is validated with the one done on the same day and then at the end of it. And then you can use this to correct for regression dilution bias. And this is the standard epidemiology approach for both blood pressure and for cholesterol. So this is what we found in our study. After very careful assessment, and in this study we did 3 ways of assessing completeness of sodium collection: the volume, the creatinine, but PABA as well. Now, I have to tell you, it is pretty painstaking to do that, and I wouldn't recommend doing that in large studies, but we wanted to validate this so that we could apply it on a 100,000 person study. And this is the correlation coefficient, the interclass correlation. It's pretty good. But you can validate it against another thing. Maybe your 24-hour urine isn't your right measure. Now, everybody acknowledges blood pressure and sodium are related. So we took the 24-hour actual measurement and looked at it versus blood pressure, and we took the estimated 24-hour urine and looked at it versus blood pressure, and we found exactly the same slope. Now, what about bias? On average, we found a tiny bias, which is a fraction of the percent, a few percent, but this bias is probably not constant. At levels below 6 grams a day, there's practically no bias. At over 6 grams of sodium intake a day, it may be underestimating. But the big debate in sodium versus CVD or mortality is not at the low level in terms of what the results show, but it's at the high level. It's not at the high level, but it's at the low level. So here we have unbiased estimates. Here, probably, you've got to inflate the value a bit. But you can do that. The second is repeatability. So this is measured 24-hour urine, measured twice. We get repeatability of 0.72. Here, this is your estimated sodium. We get a repeatability of 0.68, slightly lower, but about the same ballpark. Now, these are the three biggest studies in the literature on validation. So these are three, and the key, as I said, you need a proper 24-hour protocol, and you need to make sure you don't have incomplete 24-hour urine, so you can do urine creatinine, urine volume, and ideally PABA, but PABA is a pain. Really, it's a pain. People don't like taking it, and some IRBs won't give you permission to even do it. But we had a grant from Health Canada, and we did the largest validation study in the world. Okay, we did it in 1,700 people, but in 540 we did PABA. So I'm showing you the PABA data. And the time horizon must correspond to the right formula. And it's a different formula for different time horizons. The Tanaka formula or the Intersol formula has a different time horizon. And you need the correct specimen. And you will see this one with very careful validation. So these three, this is the only study, and happens to be ours because we were meticulous about it. And this was a separate validation study. We did that, and these were variable. And here you can see the more careful your method is, the better the ICC. Not that these are bad. Remember, a lot of biological epidemiological data, this is very good ICC values. I'm not knocking anybody. And in fact, in some ways you want to, this too is acceptable. And these did not report on the test retesting. This did. This had minimal bias. These had potentially greater biases. But this is the only study that reported versus blood pressure. The others didn't. Maybe they did have the same association, which I would expect based on other data that we know. You know about this, about the U-shaped curve. So when you do statistics on outcomes for an essential nutrient, you shouldn't do a test for linearity. You should do a test that is a spline and then test whether the spline makes physiological sense. And when you do a study with very few events, the easiest test to do is one of linearity, and that is a cop-out, really. It is more a test of lack of power than a lack of, because you can't reject linearity, so it must be linear. That's because you don't have power. So you really need power. Don't believe any study on associations with sodium if you have fewer than several hundreds, if not thousands, at least 1,000 events. So below a certain level, you get harm, and above a certain level, again, you get harm. And this has been repeatedly stated in the literature. Heaney, Walt Willett's book on nutrition, chapter 1 has this figure. We now know this is true for carbohydrates. We know this is true for fats. We published last year in the Lancet 2 papers on that. So I think you have to say, until proven otherwise, internal physiological things will be U-shaped. Hemoglobin is U-shaped. Thyroid is U-shaped. Calcium is U-shaped. Phosphate is U-shaped. External toxins like tobacco, like air pollution, are linear because the right level of those are 0. And every little bit you have more is bad for you. Now, the other thing to say is we cannot make extrapolations to levels that humans don't consume. And why am I saying this? This red line is the distribution in 100,000 people in our study on sodium before correction for regression dilution bias. This blue line is the distribution after correction for regression dilution bias. What this is telling you, and so the blue line is telling you this is the usual level because you've taken the extremes and pulled it back into the middle. There's only 0.2% of the world with a sodium below 2.3, which means we have practically no data. And yet guidelines are making extrapolations to levels for which there is no human experience. You may have experience in short-term 4-week studies or 8-week studies, but you don't have it in the usual population. You may be right in making the extrapolations, but you're at great risk because you have no data. If you go under, 1.8 here, you have no data, 0. in our entire sample of 100,000 people. This is the largest study by far in the world. So I don't know where this thing of 2.3 and 2 came from as cutoffs. We have no data, essentially. Now, these are the data from we published from Pure. Now, before this, we did a study on 27,000 people with vascular disease in the on-target transient study. But they had vascular disease. We published it in JAMA, and you could superimpose the curve. Paul wrote a beautiful editorial on it, and he raised the issue of reverse causality. Well, the way you get over reverse causality is have people from the general population and the few that have cardiovascular disease excluded, and there are one or two other little things you can do, and we'll go into that. So this is general population. 8% had CVD, 40% had hypertension, 9% had diabetes, 19% were smokers. This is what you see normally. And this is the association. And this marker is where United States and Canada are. The average is here, and if this association of a J-shaped curve is real, what you're doing is you're pushing it down here, and you will increase harm. Relatively few people are above 8 in Canada and the US. So even though you may push a few of them down, the relative benefit will be modest, and I'll show it to you formally through calculations. Now, let us see about confounding and reverse causality. Confounding we usually deal with adjusting with everything you can possibly think of. And we did that. Here are the factors we accounted for. We also did a careful propensity score matched. I have to tell you, I don't think these things fully control for all the confounders. That's why you need trials. And I'm going to end up saying, much as it is tough, we must do a trial. Otherwise, this controversy will be with us a decade from now. So when you do that, adjusting for confounders, you will see using a reference of 4 to 6 grams as your reference. If you go above it, there is increased mortality event rate. If you go below it, there is an increased event rate. You do multivariable adjustment, it still persists. Look at this. This is below 3. This is not below 2.3. Part of it is there's hardly anybody below 2.3. And the other way is, the world was so conscious about sodium, and they say, I'm going to stop taking sodium or reduce it, which we know doesn't happen. So you exclude the first 2 years of events to see whether people are continuing to do that. And you'll see, if anything, it becomes exaggerated at that end, more or less remains the same here. Then you say, let me take out the people who are high risk. So they have CVD, diabetes, hypertension, truly the low-risk people, and smokers. And what happens is the top end still shows an excess, and I wouldn't worry that the confidence limits are wide. It's a pattern that's consistent. But look at the bottom end. If anything, it becomes more exaggerated. I personally don't think this is more marked than this, but certainly every circus we did to make this result go away, it doesn't go away. So this is relevant to the average population. Now, is the Pure study alone? No. There are 14 studies that show excess events at the bottom end. Maybe all 14 are wrong, maybe all 14 are biased, but the onus is on the people who say, let's get it down to such a level to prove in good studies, not tiny studies, in good studies, either epidemiology, but preferably trials, that it is safe, and not only safe, it is effective. Let me take you through 4 studies, all with 24-hour urine. So the issue of measurement doesn't come in. This is only 2,800 people with diabetes. You can see below the range of about 3, there is a steep increase. Again, not many people, because if you did a density plot, not a lot of people are there. Another one in diabetes. This is the group with the lowest sodium, under 2.5 grams a day. Middle sodium and high sodium. If anything, it seems like high sodium is protective. These are not my data, somebody else's data. This is another type 2 study, again showing this, low sodium, high sodium. This is a very good study where they did repeated measurement. But the problem is, it's people with chronic kidney disease. So you'd say how applicable is it to the general population? I think the fact that no matter what disease, no disease, you're getting exactly the same pattern is reassuring. Now, here you have, this is the line of 2.3. This is gone, okay, 2.3. You'll see there are very few people, but this is where it's 4. 4 is here. It's pretty flat. So there's no evidence, even in this very well done study, that lower is better beyond 4. And none of the other studies support that below 4 there is lower. Now, I know Paul showed that slide from TOPE. There are problems with it because they excluded people who had events in the first few years. They did 8 to 9 statistical analysis in the paper, and the p-value is showing you is 1 out of 9 or 1 out of 8 that was statistically significant. Now, it doesn't show harm, but it doesn't show that lowering below 3 actually is associated with lower events. So we just have to be careful. Now, the other thing is there's an interaction. We know if you've got hypertension, sodium has a greater effect on blood pressure. Well, is that also true for events? So this is a meta-analysis of individual patient data from 3 studies we had data on that had 7,000 events, 133,000 people, followed for a mean of about 4 years. These are the people with hypertension. You see the U-shaped curve. These are the people without hypertension. You see the excess at the bottom end, but you don't see an excess at the top end. Is this study isolated? No. This is another study from Europe on 7,543 people. In normotensives, the association is flat. In hypertensives, you see that there is a moderate association, which is important. Now, a few years back, about 2-3 years back, the World Heart Federation convened a technical group to report on sodium and cardiovascular disease. This included 10 people. The people were chosen very deliberately. They deliberately had people on 2 sides of the debate. Paul was involved, and so was Martin O'Donnell, who was on the other side of the debate. But both are good thinkers, reasonable people. But the key point is they will bring all the evidence to the table. The other 8 people were good scientists, but had not put a stake on the ground on their position on sodium. This was a very deliberate effort. They represented 3 groups: the World Heart Federation, the European Society of Hypertension, and the European Public Health Agency. At the end of it, they said in their last paragraph, we support the conduct of definitive RCTs comparing low sodium to moderate intakes on cardiovascular events and mortality. There's insufficient information to reliably answer this question. Competing evidence from blood pressure trials and epidemiological studies, they're contradictory. Let's be frank, they're contradictory. So now I'm going to tell you 2 sets of new data. The first set is the updated 8-year results, because the earlier pure study was 4 years results. This is 8-year results. The number of events is now 6,281. It's in one study, all done in a standardized manner, and as I told you, using validated methods. Now, let me take you through this very carefully. So this is under 3, 3 to 4, 4 to 5, 5 to 6, 6 to 7 over 7. Look at the distribution. And then these are the number of events, and only the minimally adjusted result, 1 point. So 4 to 5 is the reference. It goes up a little here, 7% excess, 25% excess. At this end, 14% excess, 14% excess, 1.28. But look at the confidence limits too. With the large numbers of events, your confidence limits at each estimate is high. 750 events there, 1,224 events there, and so on. You need that kind of things in the subgroups to give you reliable estimates by subgroups. We did a multivariate adjustment. You'll see the pattern is identical. We excluded events in the first 2 years. The pattern is identical. Now, because we had 8-year follow-up, we removed the events in 1 more year, and the pattern is identical. And just like before, we looked at a low-risk cohort, and the pattern is identical. Now, the key thing is all these analyses are not changed if you adjust for blood pressure. Now, if that is so, it's telling you sodium has an effect on blood pressure, sodium has an effect on mortality, but these two effects are barely related to each other. Now, we then said the same thing, hypertensives and non-hypertensives, and you will see in the non-hypertensives, the top end, we don't see an excess, bottom end we see. With hypertensives, we see an excess both at the bottom end and the top end. If these were the data only in the literature, then I'd say you'd only need to deal with lowering sodium in this group, which is 20% of the population, not with 100% of the population. Now, the other thing is, when we look at sodium, we have to look at communities and countries with high sodium versus those without high sodium. China, we know, has high sodium, and we had 40,000 people in the analysis from China. Rest of the world, we know they have more an average sodium, like the US is just around 4, 3.9, Canada is around there. So we wanted to look at them differently. Interestingly, potassium is not that different. So when we look at the composite of CV deaths and death, however, we're seeing the same pattern for the same category of sodium. This is China, this is the rest of the world. But remember here, we have fewer people at the high end, you have many more people here at the high end, you have more people at the low end, and you have fewer people here. So the potential for harm, if we get our story wrong, is much greater in Canada and the US than it would be in China. Now, we see that excess for CVD deaths. You know, if you can scan it, I will share these slides with you later. They were being done till 8 o'clock this morning. So, and they're hot off the analysis. We see that for non-CVD deaths. Really, to understand non-CVD deaths, we have to look at it by category. You know, respiratory, cancer, injuries, whatever. But right now, we don't have the several thousand non-CVD deaths to make that assessment. What we need is an individual patient meta-analysis from all the studies or further follow-up. We are doing further follow-up in Pure. It's a gigantic task. Now, we do see a hint, and I'm going to call it only a hint, of an excess of respiratory events at the bottom end and at the top end, but the total number of events is only 250 or 300. Not enough to go into 7 subgroups or 6 subgroups. But we found something that was not being reported. There have been papers looking at insulin resistance and glucose, and I think Mary Coxwell wrote a very nice paper where they found in young people in short-term trials no effect on glucose, but there was an effect on insulin. Now, obviously, that is different from long-term differences based on sodium. And what we are finding is the higher the sodium, there's less the incidence of diabetes, and that is highly significant. You can put many zeros on the p-value. Of course, this requires replication. But that is a real signal. There's something, and these are 3,000 events, 2,851 events of new onset diabetes. On the other causes of death, there has been concerns on cancers. We had 1,500 cancers and 600 injuries. We looked at injuries as a negative control because there's no reason on earth why injuries should increase with sodium, at least that I know. So if we then find exactly the U-shaped curve, we know there is some uncontrolled confounding. But there was absolutely no association with injuries, but with cancers too, it was totally flat. The number of gastric cancers we have is not many. It's about 150, 200. So again, there could be an excess of gastric cancers and is drowned. As I told you, respiratory, there is a hint. Now, the last part of my talk, I may run over, please let me have 2 or 3 minutes. Now, this is very important. This is almost the most relevant. We're going to look at community level, which no other study could do it. Now, Pure had a hierarchical form of sampling. We sampled by country. Each country had multiple centers. Each center had multiple communities. And within each community, we had unbiased sampling. So unlike any other study, you can do group data. So I will skip that to, okay. Now, there are strengths of a community level. First, analysis, you reduce random measurement error. You minimize regression dilution bias because that isn't there in group data. and you reduce the possibility of reverse causation. The limitation is less confounders at a community level in the usual analysis, but here we have the detailed confounders on individuals, so we can use it. Of course, what we don't have is why does community A differ from community B? That we only have minimal data. We have about 10 or 15 variables. And so the average level will tend to mask differences between individuals. But if the two methods give you the same answer, that's telling you, hey, I've got a problem here. So this is the way we started with 102,000 people. We removed 7% with baseline CVD. 94,000 were in the individual level analysis. People over 50, under 50 were excluded for blood pressure analysis. People under 100 were excluded for event analysis. We were left with 255 communities, 82,000 people for clinical events, 353 communities, 90,000 people for blood pressure events. First, the InterSalt, this is the individual slope. When they went to community level by centers, it doubled the slope. We looked at the pure study. This is the individual slope. This is the slope versus blood pressure at centers. And in the 353 communities, just to tell you, 64 is the participating site. Each site had multiple communities. This is pretty much close to what the various studies have shown. Now, this is what we're finding. With major CVD, we see an association but the tick-off is around 4, uptake is over 4.5. With strokes, we are seeing pretty flat and then a significant increase, substantial increase. With MI, we're getting an inverse relationship. With CV deaths, therefore, this is averaged out and it's flat. Total mortality, it's a strong negative association. If this was the only thing I showed you, you'd say, aha, that's wonderful, exactly what I thought. But you've got to look at everything. The other thing is we looked at China and we looked at the rest of the world. China, most of the communities are here, over 5. This is where the rest of the world, most of the communities under 5, and this is for stroke because stroke had the clearest result. And when you do subgroups, you've got to take your clearest result and subdivide by clearest results. And you see this p-value for interaction of the slopes. So there may be a different result in a country or a community at high levels versus a country or community at average levels. This is potassium. We're seeing pretty flat up to there, up to about 2, and then it goes down. So higher potassium helpful. Stroke, the same thing. Myocardial infarction, not so clear. CV death, there's a significant inverse relationship, and total mortality, an inverse relationship. Now, we then said, I have 2 more slides. We then wanted to look at the population attributable risk of sodium. What we said is our data suggests that your optimal sodium versus events is 4 to 5 grams. If you're below 4 grams, as in China, there's only 3% of deaths are associated, or events are associated with low sodium, whereas 9% of the total deaths are associated with high sodium. So here it makes some sense to try to reduce this down here. But take the rest of the world, which includes Canada and the US and other countries, you're going to balance out the potential benefit with the potential harm. So we just need to be careful. The other thing is, remember, 41% of the people are at the low end here in the rest of the world. Only 18% are here. So the same excess at both ends, but because of the distribution, you get different results. With potassium, it's a different story. We're getting about a 4% effect on population attributable risk. So in summary, sodium intake over 5 grams is associated with higher rates of events and deaths, mainly seen in China, but low sodium intake is also associated with mortality and CVD, and it's consistent using studies with different methods, different populations in different countries, conducted by different investigators who don't even know each other, never talked to them till all this controversy has come up, and it persists after adjustment for everything you can think of. Now to ignore that is hell of a responsibility. And that's the charge you've got. And the other thing is, in all these studies, adjustment for blood pressure does not change results. which means the effects on clinical events and the effects on blood pressure may be quite different phenomenal. So my last slide is a population strategy for sodium reduction is maybe appropriate in countries like China with high levels, but a targeted approach for hypertensives and those who consume a lot of sodium is appropriate for US and Canada. Contrast that with potassium, I would say a broader strategy is good because high potassium is really a marker of a healthy diet, a plant-based diet. So thank you very much.